Hey, Steve. Today is a really interesting podcast for you. I've got a special guest on who's going to come any second now, and we are going to talk about endoluminal robotics. And this is one of the passions that I have for 2026. So, be really good for you because you'll understand a little bit more about the whole GI space and how these robots are going to work from a GI endoscopist point of view. So make sure that you stay to the end because there's a really interesting piece at the end of this. So strap in. It's time for us to talk about endoluminal robotics. So great, everybody. Really great to be here today. I've been looking forward to this for weeks. I'm here today with my guest, Austin Chiang.
Hi everyone. Thanks for having me on the pod.
Now, more of you probably know Austin than you know me, actually, because he actually does have a channel that he had for a long time. I think it was on TikTok, right? It was your main channel was on TikTok.
I was on everything, Steve. I was on YouTube, TikTok. I'm still on all those. Oh, YouTube I'm not as active on, but TikTok, Instagram, LinkedIn, what have you.
So they can go and find you on there and follow you on there. That's great. So do you want to just give everyone your background for those that don't know you, your background, what you do, who you are, because I think today's conversation is going to be phenomenal.
Yeah, absolutely. So I'm Austin Chiang. I'm an interventional gastroenterologist and bariatric endoscopist by training. I still practice part-time, but my full-time gig is actually as Chief Medical Officer for the endoscopy business at Medtronic. So that's me in a nutshell. As we alluded to, I'm also pretty active on social media, kind of as an educator on there, and so happy and excited to be here.
And we are going to talk quite a lot about education today because that's one of the themes. And today's theme, we're going to talk about endoluminal surgery or endoluminal interventions, and we're going to set some scene just so that everyone's on the same page because I'm sure we've got some physicians who will be on, but I have a lot of my people who follow me are non-physicians, and I want to make sure we're all grounded. As a practicing GI endoscopist. Can you talk a little bit about the endoluminal procedures that are kind of emerging at the minute and sort of becoming the mainstay?
Yeah, absolutely. I mean, at the core of what we do as gastroenterologists today, most of what we deal with are endoluminal procedures, right? Like we're talking about scopes. So for those of you who aren't familiar with scopes, it's a camera that goes in either the mouth or the anus, and we take a look within the gut, essentially. And of course, like on the broader scale, there's also other hollow organs and tubes that are involved that are not within the gastroenterology space. There can also be considered endoluminal, but as it stands today, everything is done through that scope, which is basically, it almost feels like you're taking a look within these organs with just one arm tied behind your back. I was trying to think of a good analogy to describe what it feels like to scope. And I was thinking of basically like peeling an orange with one arm or cutting a piece of fruit with one hand. It's very limiting in some ways. We've gotten very good at what we do, but I think that there are ways that can be improved. And a lot of what we've been able to do and how we've seen the field transform is through technology and innovations that have come about through those advances.
Hey, if you're enjoying this content, do me a big favor. If you will like and subscribe, that really helps my channel. But more than that, for you, what it means is that if you subscribe and hit the bell, you get notified on your YouTube every time that I drop a new video. So you don't have to rely on trying to find it from me from LinkedIn or from an email or something like that. You'll just be able to get notified straight away and get straight into the content. And remember, this year we're going to do a lot of really exciting content. So like and subscribe. Thanks very much. So we're going to hear probably lots of acronyms today: EMR,
Mhm.
ESD, ESG. Do you want to just talk a little bit about those sort of procedures so we get everyone on the baseline when we talk forwards a little bit on this?
Sure. Yeah, some of those procedures that you mentioned are currently all done by mostly advanced endoscopists who have undergone additional training, like myself, to kind of do more invasive procedures than your standard, say, screening colonoscopy or upper endoscopy. So some of those acronyms you mentioned, for instance, EMR is endoscopic mucosal resection, which is basically a polyp removal that is a little more complex because you lift the lesion and then resect it. Now, ESD is yet another level deeper within the wall when you're actually taking the lesion out. And the reason why we have these more advanced procedures to go a little deeper in the wall of the gut is is to make sure that we're getting a good resection and that you're removing anything that can potentially become, say, cancerous. So ESD is endoscopic submucosal dissection, and you are actually lifting the lesion off the submucosal layer and actually going into that submucosal layer and dissecting it out, carving out the polyp essentially. And then another acronym I think you mentioned was ESG, which is actually within the space I was trained in bariatric endoscopy, endoscopic sleeve gastroplasty. So it's basically an analog of what our surgical colleagues do with their sleeve gastrectomies, but instead of actually removing a part of the stomach, we're narrowing the stomach to have the shape of a sleeve by sewing it down endoluminally and basically reducing the size so that it kind of the stomach turns into a sleeve. And that provides the patient with restrictions so that you're not consuming as much at any given time, and therefore patients are able to lose weight. So I think those are the three basic acronyms to start. But yeah, I think that, especially among my colleagues who do these procedures today, there's been a lot of chatter about, could there potentially one day be a robotic approach to help with some of these things?
So let's talk a little bit about that because you mentioned something right at the beginning there, which was some very specialist endoscopists will do this. It's not widespread. I mean, when people think colonoscopy, that that's just a diagnostic and maybe looping some polyps. This is not what we're talking about here. This is more advanced procedures. Why is it so limited to sort of a group of experts to do this? What's the challenge?
I think the challenge is, often the disease state that requires some of these procedures, like EMR or ESD for polyp removal. These are bigger, more invasive polyps that take time and require a little extra skill to be able to do these procedures. So it takes extra training. And truth be told, I think a lot of gastroenterologists are there to, do screening colonoscopies and do some other procedures that are, a bit simpler and that they can therefore refer those other patients to those specialists. And those specialists are then able to focus and really hone their skills in that area.
So it doesn't feel like it's a lack of pathology. It feels like it's a
No.
lack. The limit is more on the lack of the ability, skills, training of trained people to do this.
Right, I would say so, especially when it comes to colorectal cancer. We're seeing more and more of that, especially among young people. I think that news just broke last week
Yeah.
where we're seeing that it's now the number one cause of cancer death among people less than age 50. So I think the pathology is only going to grow.
When I've talked to people about this, one of the things they say to me is that the training and education around this is quite intensive, and quite often you have to go to places like Japan for it. Can you explain to me a little bit more about that and how that's a little bit of a barrier?
Yeah, that's a great question. Yeah, specifically ESD and EMR for that matter are both techniques that were really pioneered out of Japan, partly because there's more pathology there when it comes to gastric cancer. And so the Japanese really pioneered the space and were able to really refine the technique around that. But as more and more folks here in the US and other countries have been trained with that experience, they're able to also train others themselves now. So I think we're seeing less of a reliance on Japan for that. But at the same time, they are the most experienced and continue to, push the boundaries of that.
And again, if I've got this right, part of the problem is you're looking end on with the scope and you're working parallel in a parallel fashion. Basically, you don't have things like triangulation or bimanual dexterity. Is that kind of how it's mainly done today?
Yes, like if you think of it, your scope, the channel through which the instrument is being passed is in the scope. So every time you move your scope in one direction, the instrument also moves in that direction. So you're limited by that kind of motion, and it's only one instrument at a time, typically speaking.
Right.
And therefore you don't have, the second hand to be able to provide traction, to triangulate as you described. And so that's, a big limitation when it comes to doing these procedures today.
So I think that that's a great segue into then why, if we could bring in robotic platforms, are we able to now really knock down some of those barriers? What's your thoughts on where we're going with robotics? Because I'm excited, but I'd love to get your thoughts on it.
Yeah, I mean, if I can imagine how we can improve upon some of those limitations, depending on I'm sure there's a lot of different ways that a robot can be designed, but there may be ways to be able to enable those mechanics that we were just talking about, right? Traction, triangulation, also closure. Right now there are endoscopic suturing devices out on the market, but are still limited to just being attachments on the scope, so limited to that kind of mobility. I would also say that, not right now, we often think of the procedures that we currently do today, and I wonder if with those, that those mechanics being enabled, if we're able to do other things that we previously haven't been able to do, if there are areas that we can access that we previously weren't able to get to, if there could be more standardization as a result. Right now, I think because of those types of limitations, there may be more variability among endoscopists in how they do their procedure. And as a result, maybe that would translate into more efficiency, potentially better health outcomes, and maybe even, democratization of procedures. If we can actually get training to be simpler and flatten the learning curve, maybe we can see more doctors being able to do this than that specific subset of doctors, and shorten the training time that it requires so that more doctors are able to do that.
You mentioned in the middle of that about full thickness. Can you just
Mm.
explain full thickness? Because a lot of people maybe don't know what full thickness is.
So the gut wall consists of multiple layers, the most inner layer being the mucosa, which is why we were talking about mucosal resection with EMR. And then beneath that is the submucosa, as you can imagine, which is then a layer in between. And then so there are multiple layers there. And ultimately, there are some cancers that can keep growing and may even grow through the wall and may necessitate, a complete resection of a piece of the bowel, which is often what, our surgical colleagues do today. And if it's a very small lesion, there are some indications where there are current technologies out there today that are being used that you can actually do a full thickness resection where you're punching out essentially a hole within the gut wall to be able to take out that entire lesion in one piece, or en bloc, as we say.
I was told many years ago that the sign of a good procedure is based on the closure when you do full thickness. It's all down to the closure, whether you end up with leaks or whether you end up with infections or problems. It's down to the quality of the closure. And my understanding is that it's challenging to close it. You either do it with like a bear trap, like an Ovesco clip where you do a bear trap, or some people try and do monomanual suturing, which I think is a great attempt. But I think if we bring in robots with bimanual ability to do suturing, do you think that changes the game in those things like full thickness resections?
Yeah, I think potentially, like you said, right now, the endoscopic full thickness resection device that I had in mind is a device that basically has a bear claw clip over which you resect what tissue was trapped within that. And that's limited by size, it's limited by what the attachment is on the scope. But if you're able to have a bimanual system, like you said, maybe there's a way to resect larger lesions and be able to confidently close the lesion up afterwards. So absolutely, I think that there may be, and those are the realms that we currently aren't able to, realize in with the current technology out there.
My feeling is that if you can start to do that, that's when you dramatically change healthcare because today a lot of those patients that could probably have one of those procedures end up in rather major surgery with an abdominal surgery. What's your
Mhm.
thoughts on if we get this right, if we get robots right, if we get full thickness closure, we allow democratization, as you said, more people can do these advanced procedures. What do you think happens to disease states as we go forwards?
Hmm. Yeah, I think that it could dramatically change how some of these diseases are treated and managed. To your point, I think what you were describing is some of these bowel resections that we see people requiring, end up with the patient having to wear a bag, having the bowel essentially empty into an external bag. And that, as you can probably imagine, is not a great quality of life for the patient, even aesthetically. You're left with a big scar, even if you're able to reverse that. So, from a patient perspective, I can imagine this potentially being life-changing.
Do you think as well that there becomes a change in the sort of the philosophy behind treatment that instead of being a procedure, it becomes a more longitudinal series of treatments? Do you think this starts to happen as you start to be able to get reproducible repositioning with robotics?
Yeah, I think that that's a possibility. I mean, I don't think anyone really knows yet, but if we're able to replicate a result over and over consistently without causing scarring or whatnot, like other things that we have to think about when we're doing these repeat procedures, then potentially, yes, there might be a way to think about how we manage a certain disease state over time.
Let's go one step further than full thickness resection. Okay. Whenever I mention these kind of endoluminal robotics, everyone says notes, natural orifice, transluminal endoscopic surgery. What's your
Hmm.
thoughts around that if we start getting robots doing that? Where do you think that ends up?
I mean, I think there's great potential there. I think for any listeners who might not be familiar with that movement, so NOTES was focused on natural orifice endoscopic procedures. You know, those are the NO letters in that acronym. And this was really a movement in the 2000s when a collaborative group between the ASG and SAGES, I believe, so a group of endoscopists and surgeons really came together to try to think about how can we transform some of these surgical procedures into endoscopic ones potentially. And even though, some of this was successful as a proof of concept, I think the feasibility of those procedures in the real world was probably more limited. But what was great from that movement was that there were a lot of learnings around endoscopic suturing and resection and dissection that translated into the endobariatric kind of boom years later, as well as third space endoscopy, meaning, ESD, POEM, which is a peroral endoscopic myotomy procedure. Like some of these procedures, I think, came from some of those, or the techniques around these procedures, I should say, came from that movement. But yeah, in terms of actual surgical, procedures like a cholecystectomy, where we're removing the gallbladder through an endoluminal approach through a natural orifice, while it can potentially be done, as I think was discovered during the Notes movement, I'm not sure that it needs to be, and I'm not sure that, we'll see, I guess, if endoluminal robotics has a role in that. I think there are a lot of variables that go into determining the success of that, but it'll be exciting. I think that there are so many different procedures that, again, we currently can't even envision because of the limitations of the technology today. And potentially having those surgical mechanics within the lumen will allow us to do things and access places in a way that we haven't been able to before.
So naturally, a lot of people watching this already know a lot of the surgical robots, the multi-port and the single ports, and they're probably just
Mhm.
sitting there thinking, well, just extend a single port. Surely it's that easy, right? You just make a single port longer. What are your thoughts on some of the challenges of making these long, flexible robots?
Ooh, I mean, if I had to just like compare that just as a gastroenterologist, thinking about what I know about Singapore as somebody who's not a robotic surgeon, but just to think that the distance from outside the body to inside the body is much shorter than actually navigating through, let's say, an entire colon and having a flexible system in that way to get through the whole colon and have all the instruments be able to be similarly flexible, but yet provide enough rigidity and strength like at the end to be able to still do the procedure well. That in and of itself, I think, poses a lot of challenges, is my guess. But it's also, again, we're thinking about the procedures as they're being done today. Is there a better way to do some of the procedures with different types of tools? It could be an opportunity to really revolutionize how we're doing some of these procedures, to rethink some of the tools that we have currently. And so, I'm excited to see what happens in this entire space.
Well, I'm a futurist and I believe it's all going to come. And I'm already seeing there's a lot of thinking behind this by a lot of companies. And I think this is like robots 2.0. It's like, I think the multiports and everything have their place. I think this is the next exciting frontier, but it's not going to be without challenges, right? We all, when you go into any space, there's challenges of reimbursement, there's challenges of location, there's challenges of training. What would you say are the current sort of infrastructure things we have to think about if we start introducing these robots?
Ooh, absolutely. I mean, I think training is going to be a big one, especially as a gastroenterologist. Robotics isn't a space that we're currently in. So it's going to require a lot of training and sort of a mindset shift around how we currently do procedures, which is very mechanical, right? And manual at this moment. I would say even thinking about the physical infrastructure, how the endoscopy rooms right now are, and where does a robot sit? I mean, I think that a lot of us who are practicing today know that every time we introduce a new piece of capital equipment, the question is, where is it going to sit in the room? Is there enough space? And a robot clearly is a big piece of capital equipment. And so that needs to be taken into consideration. And also, because we are sort of spanning different disciplines. How do these disciplines come together, collaborate, the end goal being serving more patients better. I know that there are already efforts like organizations like SAGES, like the American Foregut Society, that can really, there are collaborative efforts in facilitating these types of conversations. And I'd also want to mention that, when it comes to robotics, I think we also have to think about AI and think about, how really anything that involves software enablement can pose its own set of challenges, especially with the sort of infrastructure, when it's cyber infrastructure of any institution that is very difficult to navigate since every hospital, every health system seems to have its own, set of challenges there, and there's not much standardization there. So, so yeah, that's another thing to really think about as we move forward.
It's interesting you say that. So I kind of have a theory in my head that as the AI diagnostics gets better and diseases get picked up earlier, it kind of almost puts pressure for there to be robotic solutions to do see and treat. I think it puts pressure on it because you now see it's there and you say, okay, well, what do we do with it? Surgery doesn't have a lot more capacity. I look at the numbers over Europe that they don't have a lot more capacity. Operating rooms are full. They've not got enough nursing staff. I think the good and the bad of the AI diagnostic is that it's going to highlight disease earlier and faster and better. And then
Mhm.
we have to work out, okay, now what do we do? And I think that that's going to actually be one of the drivers of it, quite interestingly.
Yeah, that's so interesting because when you were asking earlier about the sequence of events, how we think about the care of a patient, the management of a patient and their entire journey, it could shorten, the number of steps involved between diagnosis and treatment. I think that's an interesting way of thinking about it for sure.
One of the challenges that comes with that is will be, and everyone's going to come back to it, or reimbursement. Who's going to pay for it? How are they going to pay for it? Who's going to pay for all these robots? I think one of the challenges that we'll have as healthcare providers and health systems is going to be how do you work out the long-term savings and bring that forwards into the GI endoscopist's hands today to give them the money to be able to do the thing that gives them future saving. I think clinical evidence is going to be something important. What's your thoughts on what kind of evidence models we have to build here?
Oh, I think that's a really good point, though, like what you were just saying about essentially like a value-based model. I think that it's going to, I think clinical evidence to demonstrate, especially in this day and age, efficiency and, safety and, long-term outcomes, that's going to be hard to come by because the time horizon on that, I think, is some of these decisions may need to be made sooner than that. But yes, I think that, you know, those types of things will have to be pretty critically thought about. And yeah, on a system-wide level, what sort of efficiencies and outcomes can be improved upon. It can't be limited to just, the technical success of a procedure. I think it really does need to be, how to generate evidence for anything else is long-term outcomes. At the end of the day, does it really solve the issue that we're trying to, address here?
Well, my advice to anyone who's watching who's doing endoluminal robots is that when you're building even your safety studies and your initial studies, my experience of doing robots for a long time is I always look back in hindsight and say, I wish I'd done more health economics in those first studies, even if it was collecting just basic raw data to give an inkling of the savings. So that's my advice to everyone. Make sure you include your health economics from study one.
Yeah, it's going to be very important, I would say. I agree. I think like I actually, when I was going through training, had some exposure to, health tech assessments and like cost utility analyses. I think in the landscape today, it's just so much more important to demonstrate that value.
So to wrap up here, thinking ahead, changing infrastructure, changing things takes a long time. I believe robots are coming. It sounds like you believe robots are coming. To your colleagues out there, to the healthcare providers, to the people building new GI suites, what would be your thinking of how they should be thinking ahead if you're thinking of tomorrow?
Yeah, I mean, I think I'm like you said, I am excited about the space. I see that things are already moving, right? There are companies out there that have come forward talking about innovating in this space, specifically for endoluminal robotics. And I think one of the key considerations is who is going to be the one doing the procedure, who are the patients, what are the procedures, and who are the doctors that are going to be actually doing the procedure. And, we mentioned a lot of the things that I think need to be in place in order for this to succeed, whether it's training, whether it's awareness and the mindset, whether it's, the physical infrastructure and the collaboration that's necessary. But, going back to the patient, thinking about where the patient is coming from. I think that's one thing that we haven't really touched on yet is a lot of the, assumptions that have been made thus far about the procedures that, some of these companies that I've heard about working on this are going after are GI procedures. Well, are GIs ready for this, right? I think that's a big question. Are GIs going to be the customer around this? And I think personally, a lot of these disease states are disease states where the patient is seen first by the gastroenterologist. So in terms of capturing the patient and being able to recommend a certain, procedure or approach, I think that's kind of the more efficient entry point. I'm not sure that we're quite, primed yet as a field, as a gastroenterology field for that adoption yet. I think that there's a lot of work that has to be done. But like I said, I'm encouraged by the fact that there are a lot of my colleagues who I hear, not just like in kind of casual conversation, but actual, courses being formed around endoluminal robotics, right? A lot of sessions at our big conventions and conferences discussing the idea. I think a formal movement to actually prepare for this isn't really quite underway yet, and so time will tell. But I think that those are the elements that really need to come together before I feel more comfortable that that GIs are truly going to be in this space for sure.
Yeah, and it's interesting. I lived through the 90s where it was the whole takeover of the interventional cardiologists versus the cardiac surgeons. I sort of foresee a second wave here. I've worked with a lot of surgeons who said, if that ever happens, that's going to be ours. But I always think that the interventional cardiologists got it because they were the gatekeeper of the patients. They saw
Hmm.
the patients first and they determined whether they should have a stent or a cabbage. They were the ones who determined that. I feel quite strongly that the GIs will be having a major gatekeeping role. And I would love to see that they keep this in their hands because I think it ultimately is better for the patients and the healthcare systems because I don't believe that surgeons are stood around in the operating room saying, I just wish I had something to do today. I wish I had, another 1,000 GI cases I could do this year. I just don't believe that, right? So who should take the lead on this? Who are the people who need to take the lead on this, and drive this forwards?
I mean, look, I'm biased as a gastroenterologist, but you're right. I think part of why we have innovated to the extent that we have today in this space, right? Even the fact that we have ESD, POEM, ESG was sort of driven out of that understanding that we see those patients, we help diagnose those patients with the technologies that we have today. And naturally, we want to treat the patient and see them through the entire care continuum. So in some ways, this is again just another extension of what we currently are doing with POEM, with ESD, with ESG, and I'm sure many, many other procedures that again that currently might not have endoscopic approaches, but that we see those patients and end up referring them out. And like to your point, I don't think that thus far, despite there being, thousands of these procedures being done, hasn't really disrupted, what surgeons, what their capacity has been. There have also been, a few surgeons who've also kind of bridged the gap and have, become surgical endoscopists and very skilled in this area too. So I think there's an opportunity for us to all collaborate and be able to provide the patient with kind of the best approach and technique possible.
Brilliant. Well, look, I think it's a fascinating future. I'm a firm believer that we are heading into a very exciting time in the whole GI space. And I think that Robot 2.0 is going to happen in the GI space. So it's been a brilliant conversation. I can't thank you enough for coming on and doing this today. Thank you very, very
Oh,
much for
thank you
doing that.
so much, Steve. Yeah, I greatly appreciate it too. And I'm very encouraged by your kind of confidence in the GI space being involved in this because I think there's a lot of potential.
Great. Well, thanks again.
Thank you.
If you found this video useful, it would be really great if you like and subscribe. Lots more content coming, lots more great guests coming, trying to educate, trying to give a little bit of insights into what's happening in the world of surgical and endoluminal and interventional robotics. There's all kinds of great stuff coming. So please do like and subscribe. Helps the channel, but more importantly, you get notified when I drop new content. Thanks, everyone.